Hello everyone, and welcome to a new session of clinical pharmacology and drug therapy. Today we are going to speak about corticosteroid hormone, looking on the clinical pharmacology aspect with a link to the physiology, pathophysiology, and the clinical application and the clinical practice. What we can see, how we can manage two maybe most popular cases such as Cushing syndrome related to the hypersecretion and Addison disease related to the hyposecretion of adrenal cortex. Okay, let's get started. Okay, first of all, as you can see here, the adrenal gland consists of two main parts. The adrenal gland consists of two main parts. The medulla responsible for secretion of epinephrine, and we have the cortex responsible for secretion of steroid hormone. According to the cortex layer, we have outer layer, outer zone, then we have middle zone, then we have the inner zone. The outer zone presents or produces or responsible for secretion of mineralocorticoids, and the main hormone produced from the outer zone will be aldosterone, and we know that aldosterone is hormone responsible for regulation of salt and water metabolism. So you can see here, so the outer zone responsible for mineralocorticoids, and the main mineralocorticoids in the adrenal cortex, aldosterone, and aldosterone responsible for regulation of salt and water there. Moving to the middle zone, we call the middle zone fasciculata, the middle zone of adrenal cortex. We have this part of the gland, adrenal cortex, responsible for secretion of glucocorticoids, and this is produced during stress and emotion. Corticosteroid, fight or flight. The cortisone will be produced from the middle zone. The inner zone responsible for adrenal androgen and some estrogen. So you can see here outer salt, and the middle responsible for sugar when you talk about glucocorticoids. Then the inner will be sex hormone. So we have sugar. The first we have salt, then we have sugar here, then we have sex here. So we have three parts. The outer side will be salt, the mineralocorticoid aldosterone, as maybe responsible for salt regulation. The inner one, glucocorticoids, this is responsible for stress and inflammation, and the inner part will be reticulus or inner zone responsible for secretion of androgen. Okay, so what we have here, we have a website that give us some information about the pathways for the hormone synthesis. I will click on one of these link here. Okay, so I will share the image with you for maybe a few seconds to show you what we have. As you can see here, cortisone and corticosterone synthesized start from the cholesterol, and you can see the cholesterol here. So the cholesterol will be converted to the prednisolone, and then the prednisolone will convert to with the cytochrome B450 C17 alpha to the 17 alpha prednisolone, then to the androgen. So you can see here the androgen estrogen derived from cholesterol through the pathway enzyme. Then we have progesterone here, and this is responsible for the formation of corticosteroid. This is one slide is very important. Here we can look on some enzyme. For example, here we have 11 beta enzyme. We have here 21 beta enzyme. So we have several enzymes. If you close this page, click on the second link. Okay, the second link. Okay, this is the second image here, or the second link from ResearchGate. You can see here cholesterol convert to the prednisolone through the enzyme called 1A1, and we have two pathways. The first pathway responsible for formation of progesterone ended up with estrone, and the second pathway responsible for 17 alpha, and this will lead to the androstenedione, and this will lead to formation of testosterone. So we have another pathway here to show you the hormones start maybe for formation from the cholesterol. The last one here, for example, the last website or the last image here, this image will be perfect for the demonstration. I give the credit for the website, it's not my image here, but you can see here cholesterol convert to the prednisolone through the cytochrome 1A1, then prednisolone convert to the progesterone, and then we have corticosteroid through the 1 beta 2, 1 beta 2, also cytochrome 11 beta 2, responsible for 18 hydroxycortisone, and the end result will be aldosterone. This one pathway. So another pathway will be formation of cortisone. So we have some hormones responsible for inhibit these enzymes here. So the main purpose of these slides here, and okay, what is the main purpose of this slide here? Only to show you the biosynthesis of adrenocorticosteroid from the cholesterol, and we have seen that we have several substances, intermediate substances responsible for formation of corticosteroid, formation of androgen, formation of aldosterone. Okay, now we have maybe we can ask ourselves about these steps of or this anatomical distribution. As you can see here, we have adrenal gland. We already familiar with this gland over the kidneys. Then we have adrenal medulla, and we have adrenal cortex. The main hormone produced from the adrenal medulla will be the epinephrine. Okay, what about adrenal cortex? And the adrenal cortex, we already learned we have three main parts: the outer part, the middle, and the inner. So the adrenal cortex outer part, so we have adrenal cortex produce steroid hormone. The outer part is responsible for secretion of aldosterone, and the middle zone responsible for the glucocorticoid. Then we have the inner zone responsible for the androgen secretion. So as you can see here, we have three main hormones produced from the adrenal cortex. We need to be familiar with this hormone. As a part of our lecture here, we need you at the end of this lecture to be familiar with the most popular clinical use of cortisone. As you can see here, cortisone could be used for replacement therapy. Cortisone could be used for asthma. Cortisone could be used for inflammatory bowel disease such as Crohn and ulcerative colitis. Cortisone or glucocorticoid could be used for patients from rheumatoid arthritis, allergic reaction, and cancer. We have so many factors, so many interaction with the disease. We are going to cover all these clinical use in this lecture today. Okay, so let me share this website with you again to show you the medulla here for the, you can see here the adrenal gland, give the credit to the this website, hormoneaustralia.org. You can see here the adrenal medulla over the kidneys. We have in right and left side, and the inner part, this is the medulla, the inner part responsible for catecholamine, and then we have the outer part for the cortex responsible for mineralocorticoid, and the middle part, the middle zone, responsible for glucocorticoid, and the inner responsible for androgen. Okay, moving to the next slide. So this slide is important because this slide shows us the axis between the relationship between the hypothalamus, pituitary, and adrenal cortex. As you can see here, we have the hypothalamus. I will go back again. We have hypothalamus here, then we have anterior pituitary, then we have adrenal cortex. Again, for the axis, the hypothalamus here is like major, the hypothalamus is the major part responsible for secretion a lot of hormones, and you can see our hormone here, corticotropin releasing hormone, CRH, stand for corticotropin releasing hormone, and this will be stimulate, this CRH will stimulate the ACH from the adrenal, from the anterior pituitary. So you can see the plus here, CRH stimulate ACTH, so the ACTH will stimulate, you can see the plus here, stimulate the adrenal gland. So we can type here, for example, here CRH stimulate. Let me clean it a little bit because over the screen. Okay, CRH, hormone released from the hypothalamus, stimulate ACTH, and this will stimulate. Okay, this will stimulate the adrenal cortex. To release hormone, and the main hormone will be cortisol. So this will answer the question here about what we have. As you can see here, the hypothalamus produce CRH. CRH stimulate the interior pituitary to produce ACTH. Now ACTH will be stimulated and produce mainly cortisone, a little bit of androgen, and another amount of aldosterone. So you can see here we have three main hormones, but this is the main hormone produced under the effect of ACTH. Speaking about aldosterone, we have another pathway mainly responsible for aldosterone, and this pathway called renin-angiotensin aldosterone system. It's not our topic for today. And so what we can do here to diagnose the patient, if the patient suffers from abnormalities or dysfunction of adrenal cortex, we go with the ACTH blood test. For example, if the ACTH blood test high, we have several possibilities, several differential diagnoses. Normally, we need to be familiar with what is the normal range of ACTH in the blood. So if you have patient with high level of ACTH, this give us several maybe differential diagnoses. Could be Addison disease, could be congenital adrenal hyperplasia, could be multiple endocrine neoplasia type 1, could be Cushing disease related to the pituitary tumor, for example, could be ectopic Cushing syndrome. So we have several possible causes of elevated ACTH. This one here, several possible causes for elevated ACTH. Okay. Now we move to the medication. Now we have medication in the market, and the pharmaceutical company developed this medication years ago. So you can see here we have corticosteroid. So corticosteroid is very popular medication in the practice. So number one, we have betamethasone, we have cortisone, dexamethasone, fludrocortisone, hydrocortisone, methylprednisolone, and you can see son at the end here, son. So this is a suffix here. Then we have prednisolone, prednisone, triamcinolone, and more information. So Nasacort here, for example, we cover this one, for example, in the talk about allergic rhinitis. So we cover this one in allergic rhinitis for Nasacort or Nasacort. Nasacort is like nasal drops for patients who are from allergic rhinitis, for example here. Okay, what about if you have this one, we can prescribe it for asthma, for example. This medication we can prescribe it for asthma. All these medication for the ulcerative colitis, Crohn's disease, rheumatoid arthritis. So we can prescribe it for treatment here, for the as immunosuppressant. So we have several maybe indication. The situation here when we have hypersecretion, when we have hypersecretion of cortisone, such as Cushing syndrome, what medication we can use? For example, we have ketoconazole. If the situation we have hypersecretion of mineral, we can use spironolactone. Then we have other medication. We have abiraterone. Then we have finerenone. This is a new medication introduced to the market. Okay, so we have list of medication, and this medication, how this medication work? This medication inhibit the function or biosynthesis of cortisone. So this medication used for hypersecretion. This medication used for patient with the CKD. This medication used for patient with diabetes mellitus. So we have this group of medication. Abiraterone. Okay, again, the hypertension, one of the most important one. Hypertension, diabetes, CKD, hypersecretion, Cushing syndrome, for example. Here we can type here Cushing syndrome. Okay, Cushing syndrome here. So we have abiraterone, ketoconazole, spironolactone, and finerenone. I would like to mention that ketoconazole is like considered like antifungal medication, and we have Nizoral. Nizoral available like shampoo and tablet. Okay, and available as tablet for the Nizoral. Okay, Spironolactone is belong to the adrenal biosynthesis, but at the same time, spironolactone considered like diuretic. Okay, so we have maybe several. Let me clean this one for us. Okay. Okay. So we need to be familiar with this list of medication for Cortef, for example, here hydrocortisone, Silestone for betamethasone, the Deltazone for the prednisone, Kenalog for triamcinolone. So all the brand name and generic name for the medication here. So we need to be familiar at the end of this lecture to be familiar with this name, corticosteroid, and which medication inhibit the corticosteroids. Okay, moving to how this medication works. So corticosteroid, corticoid mechanism of action. This is related to the hormone. Here we are talking about steroid hormone, and we already covered this one. Here I refer you to the pharmacodynamic slide. Pharmacodynamic slide, the first lecture in pharmacology, to show you the nuclear receptor. Okay, so you can see here the adrenal hormones bind to the nucleus receptor and lead to the gene expression, and the end will be a transcription of the elements there. When you prescribe this hormone to the patient, for example, suffer from Addison disease, and this hormones take hours to days to see the effect. It's not from first day, could be like several days, could be few hours to see the effect. This is slow action. Okay, this is a slow action, late action. We have something called immediate effect. So normally, as you remember, we have inhaler for patients from asthma, or patients from allergic rhinitis, for example. So when you have this inhaler, the effect will be immediate effect. So what happened here? They found that corticosteroid interact with the catecholamine and affect the site of action immediately, such as bronchial tree or the respiratory system, upper respiratory system. Regarding the glucocorticoids, we have receptor for glucocorticoids available, widely distributed throughout our body. Could be available in the brain, in the heart, in the GI system, endocrine gland. However, we have mineralocorticoid receptor, normally restricted to the excretory organs such as kidney, organ, colon, salivary, and sweaty gland. So this receptor for corticosteroid receptor for the mineral corticoid is like restricted to the excretory organs such as kidneys and colon and sweaty gland. Okay, the question here, if you go back again, asking about mechanism of action, we need to be familiar with the mechanism of action. As you can see here, if you maybe look on the first step here, so we have the hypothalamus. You know that the hypothalamus reduce CRH, stand for corticotropin releasing hormone. This will stimulate the anterior pituitary to release ACTH, adrenocorticotropin hormone, ACTH. Then the ACTH release from the pituitary stimulate the adrenal gland to produce cortisone. So the cortisone here, we have the S abbreviation for steroid, for cortisone. So here we're talking about the blood. Now the hormone available now in the blood, released from the adrenal gland and arrive to the blood. What happened there? So in the blood, the cortisone bind to the globulin, and this globulin called alpha globulin. 90% of hormone, of steroid hormone, bind to the albumin, alpha albumin. 90%. They said later on it's around 5 to 10% will remain free, or like maybe bind to the albumin around 5%, and this is responsible for the action. So when you talk about free responsible for the action. Okay, what happened here if you have a large excretion of cortisone, like 20 to 30 microgram per deciliter? So this protein here, binding group protein, will be saturated. So the protein binding to the cortisone will be saturated. This will lead to the increased free of cortisone and increased concentration. So if we have large amount of cortisone, if you have large amount of cortisone in our blood, this will lead to the syndrome called Cushing syndrome. And now we understand why the patients are from Cushing syndrome, because we don't have enough protein, we don't have enough corticosteroid binding globulin, and this globulin called alpha-2 globulin to bind with the steroid. Okay, moving to the next step here, what we have. Okay, also I need maybe to be familiar, need you to be familiar with these steps here. Let me go back a little bit and explain in the whiteboard what happened. And this concept is already covered in the pharmacokinetic chapter, and I refer you to that chapter to understand the pharmacokinetic. And here we're talking about the protein binding. M stands for medication. M, okay, maybe I have to make it smaller. Okay. M stands for medication, and this medication binds to the protein, and we have inverse relationship here, and the result, this here we talk about the plasma here. Okay, the result will be MB complex. So this one inactive. Here if you talk about steroid bind to the CBG, okay, they said 90% will be CBGS complex, 90%, and we have 5 to 10% will be free or binding to the albumin. So you can see here the relationship here, the relationship will be inverse relationship. So when the free protein, this is a free binding to the globulin, and this is complex here. This is inactive, as we mentioned. Okay, what happened here? When the free, this is a free in the plasma, and this is a globulin, and this. So you can see here we have inverse relationship. When the free concentration of steroid decrease in the plasma, so they ask about, okay, can you release a little bit more of steroid to the plasma? So we'll release more. So for example, here we have 10% free and 90% binding. So we have this relationship here. Okay. Okay, back again to the next step. What we have, you can see here, we talk about free, and the free steroid able to enter the cells, cross the cell membrane. You can see it here, cross the cell membrane. What happened here? And enter the cell membrane, arrive to the nucleus. Okay, arrive to the nucleus here. Okay, bind to the nuclear receptor. This is a nuclear receptor here, NR, nuclear receptor. Okay, this steroid binding to the nuclear receptor will cause DNA transcription. Okay, this will lead to the gene expression. Okay, the result will be the action here. So all these will be to the action or physiological responses. So now we understand how the hormones work. Start from hypothalamus, pituitary, adrenal cortex to the blood binding to the globulin. We have inverse relationship between globulin, and so we can type here like arrow, an inverse relationship. Then the free steroid enter the cell binding to the nuclear receptor, affect the DNA, lead to the transcription of DNA, and the result will be gene expression and cause response and action. Okay, so very important concept about the release, the mechanism of action, binding globulin, and effect on the nuclear receptor. So where is the location of corticosteroid receptor? Available inside the cell, intracellular receptor, nuclear receptor. Okay, glucocorticoids. So when you speak about the glycocorticoid, glyco talk about the glucose, for the cortex. So we have glycocorticoids. So here we have glucose. So here, if you prescribe this medication to the patient with the glucose, we expect the glucose level to be high, so or to increase. So sometimes when you prescribe cortisone to your patient, the glucose in the blood will be increased due to the effect of glucocorticoids. We have the several explanation mechanism of action. Okay, they said that how this medication glucocorticoid work. Cortisone, the main or the principal glucocorticoids available in the human body, available in the adrenal cortex. When they start looking on the cortisone blood level, they found we have peak level early in the morning of cortisone. If you look on the blood, we have peak level in the morning. Okay, this is for example like 4 a.m. or like 7 a.m. in the morning peak level. Then we have around 4 p.m. we have like maybe the lowest or that this is a peak here, this is a trough. So you can see here the peak early in the morning followed by decline, secondary smaller peak afternoon. Two things will affect the secretion of steroid. Stress will increase steroid. This is number one. They said stress will increase steroid. What else? If you prescribe cortisone from outside, the cortisone high also affect our release of cortisone. So if you prescribe cortisone to your patient, this will inhibit HBA axis, hypothalamus pituitary adrenal hormone. This will be inhibited. We ask about what is the effect or what are the effects of glucocorticoids. As you can see here, glucocorticoid or glycocorticoid normally responsible for metabolism, number one, responsible for the reaction for the stress. Glucocorticoids involved in the regulation of blood cells level. Glucocorticoid considered like one of the main agents, endogenous, exogenous agent responsible for anti-inflammatory action. We have other system effects. So we are going to discuss that in the next coming slide. So now we look on the blood cells here, and the blood cells, sorry. Looking on the effect of cortisone on the blood cells, you can imagine here you have patients from arthritis, and you prescribe cortisone to your patient, and this cortisone prescribed for like 3 months, could be 6 months or 1 year. So what happened there? If you ask a patient to implement a blood test, for example, you can see that eosinophil will be decreased, basophil will be decreased, monocyte will be decreased, lymphocyte will be decreased. All these cells considered belong to the WBC, white blood cells. So eosinophil, basophil, monocyte, lymphocyte, all these will be decreased. Okay. Here I would like to mention something. Patients are from leukemia, lymphocyte leukemia. Here what we have here, we have high level of lymphocyte, for example. They said for this reason we can use cortisone to treat leukemia because the lymphocyte will be high in this patient. So our medication glucocorticoid decreased level of lymphocyte. So this is the first indication for using in addition to the arthritis. Arthritis, one of them. Another possible treatment will be leukemia. So a corticosteroid used for treatment of leukemia, this property of decreasing white blood cells, especially lymphocyte, this is a good option for treatment of leukemia. Therefore, corticosteroid used as a part of regimen, part of protocol of treatment of leukemia. Okay, what else here? So number one, decreasing eosinophil, decreasing basophil, monocyte, and lymphocyte. On the other hand, they found the cortisone or glucocorticoid increase hemoglobin. Okay, someone may say, okay, we can use it for treatment of anemia, for example, here. Increase hemoglobin and erythrocyte. Okay, increase platelet. We can use it for patients from thrombocytopenia. Increase polymorphonuclear leukocyte. So you can see here polymorphonuclear leukocyte. This is neutrophils. So increases, and we know that this polymorphonuclear leukocyte increase during infection. So if you have patients suffer from, for example, if they have a patient come to the clinic suffer from fever, and you implement a blood test and you have seen the polymorphonuclear or the neutrophil high, you have to figure out if this patient take glucocorticoids. If the patient take glucocorticoids, this is not related to the infection. This is related to the glucocorticoids. So this is a kind of differential diagnosis between the infections and the glucocorticoid effect. So here we can type here something else. For example, okay, the infections will lead to the increased level of neutrophils, glucocorticoid increased level of neutrophils. Okay, when you have our medication here, glucocorticoid increase circulation of macrophage and lymphocyte decrease, and we know that these two types of cells responsible for fighting infection, the situation will be compromises the body ability to fight infections. So there is a risk of life-threatening infection here, because this medication decrease the function and production of lymphocyte and macrophage, and the reason that this will lead to the decreased ability to fight infections. Okay, so we spoke about the action of corticosteroid in general. Then we move to the anti-inflammatory action. Glucocorticoid produce anti-inflammatory action by reducing inflammatory response and suppress the immune response. So we have two main mechanisms. Inflammatory response will be decreased and inhibit the immune response towards the inflammation. How this medication work, possible mechanism of action. Number one, we know that glucocorticoid lower the macrophage and lymphocyte, and this is two main cells responsible for inflammation and infection. Cortisone inhibit phospholipase A2. Cortisone interfere with the mast cells and inhibit degranulation, decrease histamine release, and capillary permeability. So we have three main mechanisms. Number one, decrease lymphocyte and macrophage. Number two, inhibit phospholipase A2, and number three, interfere with the mast cells. All these will lead to the activity as anti-inflammatory action. Okay, moving to the maybe to the next action for the corticosteroid or glucocorticoids. For example, here when you prescribe it to your patient, they found the glucocorticoids responsible for catabolism, protein catabolism, responsible for lipolysis, responsible for all these lead to the providing energy. So maybe destroy the protein to the amino acid and also catabolism of lipid and produce fat acid. Amino acid, fat acid will provide our body with the energy, and this will lead to the enhanced synthesis of glucose. And this explains what happened when you prescribe cortisone to your patient. The situation will be the patient may suffer from diabetes due to the increased level of glucose in the blood. Okay, moving to the next one here is important for us. Glucocorticoid, if you prescribe it to your patient, they found the glucocorticoid with the high doses. They found stimulate gastric acid and the pepsin. So gastric acid and pepsin, this will lead to the peptic ulcer disease. So we have another case here. So you can see diabetes, you can have like peptic ulcer disease. What else? This is high doses. Speaking about chronic treatment, like high doses chronic treatment. What happened here? The patient may suffer from bone loss. This is due to this will lead to the increased risk of osteoporosis. Someone may ask, what is the mechanism? How glucocorticoids lead to the osteoporosis? As you can see here, the statement, glucocorticoid increase risk of osteoporosis by several mechanisms. Number one, this medication work on the intestinal. The cortisone work on the intestinal, but by antagonize the action of vitamin D on the GI system. Number one, antagonize the action of vitamin D on the GI system, and we know that vitamin D is responsible for calcium transport, number one. Number two, cortisone work on the renal system by stimulate excretion of calcium in urine. So we have calcium will be excreted in the urine. Okay, number two, enhance calcium excretion in the urine. Number three, black bone formation. Okay, black bone formation. And number four will be decrease sex hormone synthesis. So we have four mechanisms of action how the cortisone glucocorticoid increase risk of osteoporosis. Number one, antagonize vitamin D on the intestinal level, increase calcium excretion in the urine, black bone formation, and the last one will be decrease sex hormone like estrogen hormone. Also, would like to mention here, cortisone may cause myopathy and lead to the weaknesses, and the patient start complaining from weaknesses there. Okay, we're done with the speaking about the glucocorticoids. Then next one will be two main hormones, as we discussed. If you go back again for the hormones, we discussed that with the adrenal cortex. We have three. With the adrenal cortex, we have three main hormones. If you remember that from the adrenal cortex, we have cortisone, we have aldosterone, then we have androgen. Okay, these hormones produced from the adrenal cortex. So we start talking about what happened if the aldosterone is elevated. Aldosterone belongs to the mineralocorticoids. So here we have mineralocorticoid, and the main agent produced from the adrenal cortex will be aldosterone. The main action, the main site of action of the aldosterone will be the kidneys. And here we talk about collecting duct. So aldosterone affects the kidney and mainly collecting duct. What happened? Aldosterone responsible for reabsorption of sodium, bicarbonate, and water. Okay, reabsorption. That means aldosterone will keep water, bicarbonate, bicarb, and sodium. Will keep this substance in our body. Keep it, retain. Okay, retain. So what happened if the sodium retain in our body? The sodium retain, the result will be increased blood pressure, hypertension. If we have increased retain of water in our body, the result will be edema. So you can imagine here aldosterone responsible for the keeping water, bicarbonate, and sodium in our body, and the patient may suffer from hypertension, blood volume. So we have the possibility here of the abnormality. So blood volume will be changed, the blood pressure will be changed. Yes, blood volume talk about edema and water there, and sodium talk about blood pressure. Okay. Okay, next step here. So we already covered what happened with these three variables: sodium, water, bicarbonate. Another maybe agent will be potassium. So aldosterone retains sodium, but on the other hand, enhance elimination of potassium. So here we talk about something called hypokalemia. Hypokalemia means decreased level of potassium in the blood. Okay, so this is the main action of aldosterone: retain sodium and water, bicarbonate, and decrease reabsorption and enhance excretion of potassium enhance excretion of potassium in the urine. So enhance potassium excretion in the urine. Okay, we have some cases called hyperaldosteronism. The hyperaldosteronism means increased level of aldosterone in the blood, and we can treat this patient. For example, we have several causes. If you talk about a tumor, for example, you need to go with the surgery. Some medication could be used to treat hyperaldosteronism. Will be spironolactone. We are going to cover that with the spironolactone with the diuretic. Okay, diuretic chapter, I refer you to diuretic chapter, diuretic lecture to learn more about spironolactone, mechanism of action, and clinical use. Here another medication. Spironolactone is hormone produced from the adrenal cortex. Normally we don't use aldosterone in the clinical practice, but we have another synthetic agent, synthetic hormone used in the clinical practice. This synthetic hormone called fludrocortisone. Fludrocortisone is like a replacement for the aldosterone due to the long duration of action, and maybe more beneficial effects. We are going to see the table, the information regarding this function there for fludrocortisone. So in our body, we have hormone released from the cortex called aldosterone. We discuss the action for sodium and potassium. If the patients are from hyperaldosteronism, we have medication called spironolactone, work as aldosterone antagonists, spironolactone. In the practice, if we have hyposecretion, if we have deficiency, we can prescribe fludrocortisone. When you have patients from Addison disease, we can prescribe cortisone in addition to the cortisol. Okay. Okay, this table here considered like one of the most important table in the clinical practice regarding the corticosteroid, the classification. Here we talk about classification of corticosteroid. We have three main group we need to focus on. Number one, we have short acting between 8 to 12 hour. So short acting 8 to 12 hour. Then we have intermediate acting 12 to 24 hour. Then we have long acting, could be more than 24 and 24 hour to more than 36 hour. The last group will be mineralocorticoids. So we need you to focus on the glucocorticoid. The glucocorticoid, we have three main groups for the gluco. We have short, intermediate, and long. Okay, giving medication belong to the short-acting corticosteroid, 8 to 12 hour. We have hydrocortisone and cortisone. Giving medication belong to the intermediate-acting glucocorticoids, 12 to 24 hour. We have prednisone, prednisolone, methylprednisolone, triamcinolone. Giving medication belong to the long-acting glucocorticoid. We have beta-methasone, we have dexamethasone. So now we have three groups of medication: short, intermediate, long-acting, depends on the time. They found later on from the name here when we talk about the glycocorticoids, here we talk about the cortisone level, the anti-inflammatory effect. Anti-inflammatory effect, that means we use this medication as anti-inflammatory for patients suffer from pain, inflammation, arthritis, whatever. So the standard for comparison will be hydrocortisone, cortisol. So the standard will be 1:1 will be cortisone. You can see here. So again, the cortisone, hydrocortisone carry the effect of salt retaining and anti-inflammatory things. So number two main function: salt retaining, and anti-inflammatory. Anti-inflammatory beneficial effect. Salt retaining may cause increased blood pressure, for example. Hydrocortisone 1:1. What about cortisone? Cortisone 0.8, very close to the hydrocortisone, and both of them considered short acting. So giving medication considered like anti-inflammatory 0.8, we have cortisone. For intermediate action, we have prednisone, prednisolone, methylprednisolone, and triamcinolone, very close to each other. We have 4 times more potent than cortisone as anti-inflammatory. Prednisolone and methylprednisolone 5 times more potent and triamcinolone. So you can see it's here all close related. So the intermediate like 4 to 5 times more potent than cortisone as anti-inflammatory medication. So if you're looking for medication with a moderate anti-inflammatory, I will select prednisone, prednisolone, methylprednisolone, triamcinolone. What about the salt retaining? So you can see here the salt retaining become lower, 0.3, 0.3, 0.25, here zeros for triamcinolone. There is no risk of, for example, if you look on the zero, we have no risk of the salt retaining. Some textbook they mentioned 0.05, that means significantly lower possibility of salt retaining. Okay, moving to the next group, we have long-acting glucocorticoid, it's 24 hour to more than or equal 36 hour. We have beta-methasone and dexamethasone. Beta-methasone, we can look on the potency as an anti-inflammatory medication between 25 to 40, and then we have 30 times dexamethasone. What about the salt retaining? It's very insignificant. You can see here it's a statistically insignificant effect on the salt retaining, 0. And other textbook mentioned 0.05. It's like significantly less effect on the salt retaining. No risk, here we type here, no risk of, for example, salt retaining. Okay. We done with the first pass with the glucocorticoid. This is a classification. Move to the next one, to the next group of medication. We have mineral corticoids. Mineral corticoids is important. Aldosterone, okay, looking on this anti-inflammatory, we don't prescribe aldosterone to the patient. Aldosterone, if you look for patients from arthritis, you can see the effect 0.3. Okay, that's fine. I can use it. But however, if you look on the salt retaining, aldosterone 3,000 times more active, more effective in salt retaining. There's a high risk of salt retaining, edema, blood pressure, high risk. We don't recommend to use aldosterone for the patients from inflammation. It's not in the clinical practice, but we can use it for some cases, for example. Okay, next we have in the synthetic medication called fludrocortisone. Fludrocortisone 10 times more maybe potent than cortisone as anti-inflammatory. However, consider like 250 times more powerful than cortisone as salt retaining. Okay, so now we have this table here. We need to be familiar with this table here. We can ask question, which of the following glucocorticoid considered like 40 times more potent than cortisone? Which of the following medication considered like 30 times more potent than cortisone? Give me medication with a less or no salt retaining effect, for example, here. So you can see the situation for no or less for we have that group of medication there. So we need to be familiar with all these processes. Okay, very important table to remember, memorize, and master the information in this table. Short duration, intermediate, long duration. Then we have mineralocorticoid, aldosterone, fludrocortisone. I will repeat the category, the main category. We have short duration of action. Okay, we have short duration of action. 2 medication, hydrocortisone, cortisone, 8 to 12 hours. Intermediate acting, prednisone, prednisolone. Long acting, betamethasone, dexamethasone. Okay, therapeutic use of corticosteroids. The main clinical use here you can see we use it for replacement therapy if the patient suffers from adrenocortical insufficiency. This could be primary related to the Addison disease. For example, we have the adrenal gland unable to produce the hormones. Could be secondary related to the pituitary gland, or could be tertiary regarding the hypothalamus lesions, or could be congenital adrenal hyperplasia. So the replacement therapy could be for primary, secondary, or congenital. We use a corticosteroid for replacement therapy. We use corticosteroid for diagnosis of Cushing syndrome. We use glucocorticoid for inflammation, treatment of allergy, and we prescribe it to the mother to during pregnancy to accelerate lung maturation in the fetus. So this explains the summary of clinical use of clinical use of corticosteroid, but we have another 2 tables explain in details a lot of clinical use of cortisone. Okay, what happened here if the patients are from Addison disease? So Addison disease considered like primary adrenocortical insufficiency, Addison disease. So the lesions, the disease will be restricted to the adrenal cortex. So as you can see, Addison disease is related to the adrenal cortex dysfunction, diagnosed by the lack of response to the corticotropin administration. The treatment here we prescribe, we try to compensate, replace the hydrocortisone. So we need to hydrocortisone. We need to replace the salt. We are going to prescribe fludrocortisone as salt retaining activity substance. So we need 2 agents to be prescribed in patients from Addison: hydrocortisone and fludrocortisone. Hydrocortisone for the gluco, and fludrocortisone for the mineral. They try to remind us when you prescribe hydrocortisone to your patient, try to mimic the circadian rhythm. They found the circadian rhythm, we have high level of cortisone in the morning and lower level in the afternoon. For this reason, we prescribe hydrocortisone, two-thirds of the dose in the normal dose in the morning, and one-third will be in the afternoon. So as you can see here, normal daily production, they try to monitor the production of cortisone, circadian rhythm of corticosteroids. Here talk about cortisone. They start looking on the morning what happened there. Okay, rate of secretion at the in the morning, 8 in the morning, 8 a.m. in the morning. Okay, we have 16. Okay, and the PM, 4 p.m. we have 4. As you can see here, the concentration, we try to mimic the concentration. We give high doses in the morning, in the afternoon we give lower dose. However, the same not apply to the aldosterone, because we have fixed concentration. We prescribe the same amount of fludrocortisone morning and afternoon. No need to this fixed combination. Okay. Okay, so the next one, so the first one will be the first use for replacement therapy will be Addison disease. We tried to understand what happened with the diagnosis of Cushing syndrome, and this is the second use. So the first use, I will go back to the slide. Okay, so replacement therapy, we discuss Addison disease with you, and then we discuss the second one, diagnosis of Cushing syndrome. Here, the second slide. So what happened here? Cushing syndrome could be related to the hypersecretion of corticosteroid, glucocorticosteroid. The hypersecretion could be related to the tumor in the adrenal gland, tumor. And when you have a tumor, that means this cells become unable to respond to the normal stimulation. This tumor will not respond to the cortisone. Okay. On the other hand, if you have the reason for the Cushing syndrome, increased level of cortisone in our body related to the anterior pituitary dependent, could be tumor there, could be hyperplasia. So when you prescribe cortisone to the patient, when you prescribe dexamethasone to the patient, so the dexamethasone will suppress the release of cortisone. So the situation here, you prescribe dexamethasone to your patient. If the cortisone level in the blood decreased, so here we talk about blood. If the cortisone level decreased in the blood, this will give us maybe indication that the patient suffers from lesion in the anterior pituitary gland. Okay, if the cortisone level remain high, does not suppressed by the dexamethasone, this will give us some maybe assumption that this lesion could be an adrenal tumor. We need further investigation. So here we have kind of differential diagnosis to identify, is this a lesion related to the anterior pituitary gland or the adrenal gland? Is this a tumor or hypersecretion? We go from there. Okay. The question here, how this medication or like still speak about clinical use of glucocorticoids. We discussed Addison disease. We discussed with you diagnosis of Cushing syndrome. The third one, glucocorticoid, considered one of the most popular medication to relieve inflammatory symptoms, significantly reduce symptoms of inflammation. We can use cortisone for rheumatoid arthritis, patients suffer from osteoarthritis, inflammation, skin inflammatory condition. We can use it for asthma, and the most popular one will be the inhaler. Okay, then we have allergic rhinitis. We prefer to go with the topical. And we have drug allergy with the cortisone. We have several, maybe could be oral, could be injectable, could be ointment, could be cream. So we have several maybe application. Okay, so pharmacokinetic here, talking about pharmacokinetic of glucocorticoids. Glucocorticoid available in several pharmaceutical form, available as oral, available IV, intravenous, intramuscular, could be available as injected inside the joints. We call this one intra-articularly injection. Okay, topical, we have the cream, ointment, enema, could be inhaler for patient with asthma. Um, okay, this is you can see it here is available like tablet, available like ambule, available like injection cream, um, pharmaco. So what happened here if we need to use the cortisone during pregnancy? They found the safest medication during pregnancy belonging to the glucocorticoid will be prednisone. Prednisone is a broad drug, as you can see here. Prednisone is a broad drug and unable to convert to the active medication in the fetal liver. Okay, in the fetal liver is unable to convert to the active. So therefore, the prednisone considered safe during pregnancy. The question here: which of the following glucocorticoids considered the safest medication during pregnancy? So we have prednisone. Another important topic here, we have suppression of the axis HPA. HPA stands for hypothalamus pituitary adrenal cortex. When you prescribe cortisone to your patient, large doses and more than 2 weeks time, so large dose of glucocorticoid and more than 2 weeks time, this will lead to the suppression of HPA axis. And we have some recommendation to avoid, how to avoid this suppression. So when you prescribe high doses, more than 2 weeks, this will lead to the suppression of HPA axis. The question, how to avoid this suppression? They recommend to use alternative day regimen. One day you prescribe it, another day like free or break. This alternate day regimen allow the axis to recover. So this will be lead to the maybe avoid the suppression of HPA axis. Okay, so we're done with the maybe general information about the adrenal glucocorticoids. Here we have a list of clinical case we can use the adrenal corticosteroid. We can use for patients from dermatitis, pemphigus, collagen disease, lupus syndrome, polymyalgia, cranial giant cell arthritis. Then we have acute asthma, acute lymphatic leukemia, hemolytic anemia, severe allergic reaction, organ transplantation rejection. So we use it as immunosuppressant, acute spinal cord injury. So you can see it here. All these could be indication to use adrenal steroid. Next maybe indication, you can see here rheumatic fever, rheumatoid arthritis, ankylosing spondylitis, ulcerative colitis, Crohn's disease, bronchial asthma, allergic rhinitis, pulmonary fibrosis, prevention of adverse reaction to radio contrast, thrombocytopenia. Thrombocytopenia here means decreased platelet here. So if the patients are from decreased platelet like idiopathic, the cortisone will be prescribed. Nephrotic syndrome, eczema, gout, acute gout, we can prescribe it. Hypercalcemia, if the patients are from increased intracranial pressure. So we have a lot of indication clinical use for cortisone. Preterm labor, because we already discussed that this enhanced lung maturation in the baby during pregnancy. Myasthenia gravis, we can use cortisone for cancer. All these maybe present the wide range of clinical use of cortisone. Okay, side effect. It's very important to take it on consideration. Okay, so you can see here what we have. Cushing syndrome, could be Cushing disease, impaired resistance to the infection, salt and water retention. Here we talk about hypertension. This will lead to the hypertension. Hypokalemia, due to the aldosterone effect. Hyperglycemia, this is increased risk of diabetes. Myopathy, proximal myopathy, risk of osteoporosis, growth retardation in the children, aseptic necrosis of bone, peptic ulcer, mental change, anxiety, insomnia, psychosis, posterior cataracts. So you can see all the information here related to the adverse drug reaction, unwanted effect, especially during chronic administration. We need to be familiar with all these medication. What do you think here? So one of the side effects for cortisone will be hypokalemia, which means decreased level of potassium. Hypokalemia, decreased level of potassium in the blood. Okay, hypertension, hyperglycemia. So we need to remember all these side effects. Okay, I'm going to focus on some maybe important side effect. You can see it in the practice. We already discussed the suppression of the HbA. Another important side effect will be osteoporosis. Osteoporosis, one of the important side effect. The most common side effect, osteoporosis. Okay, glucocorticoid may cause osteoporosis by 3 mechanisms or 4 mechanisms, as you can see here, and we already covered in some other places. I refer you to this slide before, how the cortisone cause osteoporosis, may cause osteoporosis. We have 4 mechanisms. Antagonize vitamin D, increase excretion of calcium in urine, black bone formation, decrease sex hormone synthesis. They said here, what happened if you alternate day dosing does not prevent osteoporosis? They said, okay, this will not prevent osteoporosis. So when you use alternate day dosing here, does not prevent. We use this regimen here, only to prevent HbA suppression. Okay, we use it for HbA suppression. Okay, so it's not effective for the osteoporosis. So the question now, what is the most common adverse effect of long-term glucocorticoid use? Increase muscle mass, osteoporosis, improve bone density, enhance intestinal calcium absorption. Okay, the first one is not correct, because cortisone decrease muscle mass. Okay, number D, enhance intestinal calcium, no. Increase calcium excretion, not correct. Improved bone density is not correct, because decreased bone density with the effect of cortisone. So the correct answer will be osteoporosis. What is the most common side effect? If you scroll back again, so you can see here the most common side effect of cortisone will be osteoporosis. Okay, adverse effect related to the cortisone, we have Cushing syndrome, redistribution of fat in the body. So we have all the maybe symptoms there, such as puffy face, increased body hair growth, acne, insomnia, increased appetite. Patient may suffer from cataract, hyperglycemia, hyperkalemia. We have slide regarding the Cushing syndrome to cover the information there. So we need to remember hyperglycemia, hypokalemia, cataract, and fat distribution in the slide, coming from when you treat the patient with the glucocorticoids. Okay, so what happened here? So you are treating the patient with the cortisone, and you decide to stop this medication. We know that the cortisone, this with the high dose and long term, more than 2 weeks, this will lead to the suppression of HbA, stand for hypothalamus pituitary adrenal cortex. They said abrupt withdrawal of cortisone can cause acute adrenal insufficiency. So we don't recommend to stop this medication suddenly, and this could be lethal. So please remember that when you have patient on the glucocorticoid for chronic treatment, chronic administration, long term, try not to stop this medication suddenly, because this will lead to the acute adrenal insufficiency that can be lethal. This medication, if you stop this medication, will cause psychological maybe disorders. For this reason here, they have recommendation to gradually decrease the doses, and we have the regimen for that. For example, for 2 weeks, decrease the dose gradually with a careful monitoring of vital sign and all complication that might happen. So the advice here to decrease the dose gradually to avoid acute adrenal insufficiency. Okay, let us cover the Cushing syndrome here. Because it's closely related to the pharmacology, we need to understand what happened there. Cushing syndrome could be arise from the endogenous causes or exogenous causes. And some of the maybe research, they said exogenous causes considered like Cushing disease or Cushing syndrome, depends on the situation. So we can follow up with the steps here. In this slide, we are talking about the endogenous causes. Okay, number one will be ectopic ACTH syndrome, could be small cell cancer, small cell lung cancer, could be lung cancer here. Okay, produce the ACTH, this is one reason. Okay, you can see here the ectopic ACTH syndrome, lung cancer, produce ACTH. ACTH stands for adrenocorticotropin hormones, and this will stimulate, ACTH will stimulate the adrenal cortex and increase level of cortisone, and the patient here suffers from Cushing syndrome. This is number one. Another way, hypothalamus will be activated, produce large amount of CRH. Okay, the CRH high concentration will stimulate the pituitary to produce ACTH. The high ACTH will stimulate the adrenal cortex, and this will lead to the increased level of cortisone. So this is number one. So this is number one here. Number two could be number three here. Number four could be we have adrenal tumor or adrenal. So you can see it here if you click on the next step, that adrenal cortex may suffer from adenoma or carcinoma, and this will lead to the increased level of cortisone. And the patient at the end, they will suffer from Cushing syndrome. We need to make a differential diagnosis if you go back to the slide for dexamethasone suppression test. Another maybe possibility, if you remember the pituitary, if we have tumor in the pituitary, this will lead to the increased level of ACTH. Now we understand the endogenous causes of Cushing syndrome. Could be ectopic ACTH syndrome, could be increased level of CRH, could be increased level of ACTH due to the tumor, or adrenal cortex adenoma or carcinoma. All these will lead to the increased level of cortisone in the human body. So the situation, we have Cushing syndrome, we need to decide what is the cause, how to approach the patient. Okay, so you can see that tumor here stimulate the secretion of ACTH. Again, adenoma will stimulate increase secretion of cortisone. Here, if you prescribe, what we have here, adenoma, carcinoma, this is not will not respond. I will say there is no response to the dexamethasone suppression test. No response. Okay. About exogenous causes here, we have a medication. When you prescribe prescription here, the patient come to the clinics from rheumatoid arthritis or like ulcerative colitis or like Crohn's disease, and you prescribe cortisone to your patient from external source. Normally you prescribe it like for asthma, as you can see, arthritis, immune inflammation, immune disease. So we prescribe oral. Could be oral. This is the most common maybe cause when you prescribe oral or parenteral injection. This is the most common causes here. Okay, this increased level of cortisone from external sources. So the cortisone that will be high in our body, and this will lead to the Cushing syndrome. Very rare to for example, when you use inhalation to see Cushing syndrome, or when you use ointment or cream to see Cushing syndrome, is very rare in the practice. This is the most common maybe form in the practice. Okay, we need also to remember we covered this concept here we covered it in our discussion. If you click, so when you prescribe cortisone to your patient or glucocorticoids, you can see here cortisone practice something called negative feedback on the pituitary Okay, also negative practice negative feedback on the hypothalamus. This will lead to the decreased secretion of ACTH and CRH, and the patient here suffer from suppression. The patient suffer from suppression of HPA. So therefore, it's very important when you decide to stop the medication, gradually to avoid acute adrenal insufficiency. Okay, Cushing syndrome here, patients, what type of symptoms can we see here? The patient may suffer from increased weight gain, buffalo humps, moo face, red cheeks, thin arm and legs, thin skin, cataract, normally posterior cataract, hypertension, muscle weakness, impaired wound healing, easy bruising, infertility, if we talk about male, erectile dysfunction, impotence, decreased libido, decreased sexual desire, menstrual disorder, talk about female, osteoporosis, diabetes. So all these consider like the Cushing syndrome side effect, and you can see this all these symptoms here when you prescribe cortisone to your patient also. Okay, next slide, we are going to speak about treatment of Cushing syndrome. As you can see here, the main answer for this treatment of Cushing syndrome here, the main answer for this question, how to treat patients with Cushing syndromes, as you can see, surgical treatment, the first line. First line to remove the tumor. Tumor responsible for the Cushing syndrome could be adrenal, could be pituitary tumor, could be lung cancer. So we need to, the surgery will be the first approach for the patient. We can use some palliative therapy such as ketoconazole. Ketoconazole work by inhibit steroid synthesis, and ketoconazole belong to the antifungal medication. We can use metarabone, block production of cortisone, metotan, considered like adrenoleutic drugs, and used for carcinoma, adrenal carcinoma. This is a new medication, baseroatide. This reduce ACTH release in the Cushing syndrome. This work on the pituitary gland, inhibit release of ACTH baseroatide. Then we have mifepristone. Mifepristone considered like receptor antagonist, glucocorticoid receptor antagonist, mifepristone. Okay, and this will control hyperglycemia also. Radiation therapy, one of the option, lifestyle modification to control diabetes and hypertension and increasing weight. All these approach will be for the patients from Cushing syndrome. We need you to focus on this group of medication. Ketoconazole inhibit the steroid, metarabone block the production, metotan adrenoleutic drugs, baseroatide produce ACTH in Cushing syndrome, mifepristone work on the receptor. Okay, so and the rest will be maybe followed by the slides here. Okay, Cushing syndrome treatment focus on the drug therapy. Here we try to focus medical therapy. We have oscillodrostate or oscillodrostat. Then we have ketoconazole. Then we have metarabone. We have metotan. We have etomidate. Then we have surgical therapy. Again, highlight that the first line treatment will be surgical therapy. Okay, more information here about the oscillodrostat. Here, block cortisone synthesis by inhibiting 11 beta hydroxylase in the synthesis. This medication may cause QT prolongation, hypertension, hirsutism. Ketoconazole, another option for the treatment, but they try to remind us ketoconazole may cause liver toxicity. Okay, then we have metarabone, inhibit or suppress hypercortisone. We have metotan used for the carcinoma, considered like anti-cancer medication. And the last one will be etomidate IV anesthetic. This is not belong to the cortisone. Nothing to do with the cortisone inhibition synthesis or receptor. So here, if the patient suffers from severe cases of hydrocortisone, severe case of hydrocortisone, not response to the traditional treatment, this is a resort treatment for us, IV anesthetic. IV anesthetic used for severe cases of hyperaldosteronism. Okay, so hypercortisolism. So etomidate, I will click on the link here. Let me share the screen. Okay, so you can see here for this medication approved 2020, oscillodrostate tablet for use, indication for the okay, if you maximize the base, only to focus on the brand name, Estrosia oscillodrostate tablet. Okay, how this medication work? Cortisone synthesis inhibitor indicated for the treatment of patient with Cushing syndrome for whom pituitary surgery is not an option or not curative. So it's not the first line medication will be surgery. We can use it for the patient suffer. Okay, it's available like tablets here. Okay. We're done with the Cushing syndrome. How we can treat patient with Cushing syndrome here? We try to inhibit the cortisone, glucocorticoid. We have ketoconazole, metarabone, metotan, etomidate for the severe cases. Etomidate is for severe cases only. So, okay, if you click on the etomidate, let me share the title for this research article. Etomidate in the control of severe Cushing syndrome by neuroendocrine carcinoma. So we use it, very effective drug in severe Cushing syndrome that is refractory to the ketoconazole. So you prescribe ketoconazole to your patient, there is no response. We use this one for severe refractory cases of Cushing syndrome. Done with the Cushing syndrome, we discuss all the possible approach for patients with Cushing syndrome. Moving to the patients suffer from adrenal insufficiency. So adrenocortical insufficiency, we have case called Addison disease. So the lesion will be in the adrenal gland. It could be mostly related to the immune disease. The situation here will lead to the decreased secretion, synthesis of adrenal corticosteroids. The patient may suffer from weaknesses, fatigue, weight loss, hypertension, hyperpigmentation, inability to maintain blood glucose level during fasting. Could start primary or secondary during between 20, 40 or 50, 60, depends on the age and category. The question now, how to treat your patient? We need to prescribe hydrocortisone daily. We need to prescribe fludrocortisone also for the alternative for the salt retaining activity. So what we have here, we have the treatment could be to replace glucocorticoids. We prescribe hydrocortisone to replace glucocorticoids. To replace the salt retaining, we need to prescribe fludrocortisone. They try to remind us when the patients are from Addison disease, the symptoms will appear when the 90% of the adrenal gland will be destroyed. So when the 90% of the adrenal gland destroyed, the patient starts suffering from symptoms. And therefore, it's very important for routine visit to the clinic, for blood tests, for routine maybe X-ray, routine physical examination to discover any early symptoms of abnormalities. If you found any early symptoms of Addison disease, we can intervene early and prevent patient from consequences. Okay, here we give you a slide like diagram slide. Try to figure out the causes of adrenal insufficiency. As you can see, could be stress situation, could be surgery, could be infection, could be trauma. All these options on the table for patients from adrenal crisis, acute adrenal insufficiency. This is emergency case, acute. So the most common case will be For example, you place the patient on cortisone and you stop this medication abruptly. So we don't recommend to stop this medication abruptly. This will lead to the most common cause of acute adrenal insufficiency. Stop the medication abruptly. How to treat the patient? Again, hydrocortisone, IV. Then we have fluid replacement. Then we have fludrocortisone, and you go with all details with number there. Okay, this will conclude our lecture about corticosteroid hormones, and I hope you maybe enjoyed this lecture. I hope you learn a lot of information about the glucocorticoids, about mineralocorticoids, about anti-inflammatory action, about the salt retaining, the medication, the category of the glucocorticoids. So we have hydrocortisone, cortisone, prednisolone, methylprednisolone, dexamethasone, betamethasone, and aldosterone, fludrocortisone. So all these medication belong to the cortisone. We discuss Cushing syndrome with you. We discuss Addison disease, how to approach the patient, what type of medication, the potency, for example, which of these, for example, maybe agent, because they're like 40 times, 30 times more potent than hydrocortisone. All this information very important for the clinical practice and application. Thank you so much for your watching, and have a great day.